Welcome, everyone. Thank you so much for joining us for our April Data to Drive Decisions webinar. Our topic today is the introduction of a brand new analysis from CIVHC called the Health Equity Analysis. We're really excited to share with you today. My name is Claire Leather. I am the Public Reporting Program Manager here at CIVHC and will be the facilitator for today's session. A couple of housekeeping notes before we jump into the presentation. All lines are muted, but please feel free to jump in the chat box with any of your questions. This is meant to be an interactive experience, and we'll do our best to address any clarifying questions as they come up. We do have a formal Q&A at the end where we'll address any of the leftover chat questions. Webinar is being recorded, and the slides and a link to the recording will be posted on the event resources page at civhc.org after the event is over. So joining me today are two wonderful presenters. Jamie Ransahoff is a health data analyst from the Human Research Services Institute, or HSRI for short. HSRI is our longtime data warehouse vendor and partners with us to create certain analytics like the analysis we're going to review today with you guys. Jamie will be describing more of the statistical pieces of the report, and Carrie Frank is here today, the Vice President of Communications and Marketing here at CIVHC. She'll be demoing the new tool for us and sharing some of those high-level insights and findings. This is our agenda for the day. We're going to go over a brief background for the analysis, or why we created it. We're going to learn how to use the tool and discuss those early insights and findings. We'll also be going over some use cases, potential use cases, and then we'll be answering some questions. So if you're new to us, new to CIVHC, just a little bit about us. Our mission is to empower individuals, communities, and organizations through collaborative support services and healthcare information that advance the triple aim of better health, better care, and lower costs. CIVHC is a nonprofit. We pride ourselves on being nonpartisan, objective organization. And this is who we serve. So we serve a wide array of partners. We like to call them change agents. These are the folks who have the boots on the ground, the ones that are making a difference in healthcare, from individual employers to hospitals, clinicians, state agencies, legislators. But as you can see here from this visual, at the center of everything we do is the consumer. All of our activities are aimed at improving the lives of Coloradans, ultimately by advancing the triple aim. And that's really what guides all of our work. So today we're going to be talking about data that's in the Colorado All-Payer Claims Database, which CIVHC administers. So what is in the Colorado APCD? So we have 870 million plus claims and counting from 36 commercial payers, including Medicaid and Medicare. We cover 5+ million lives in the state, including 50% of the self-insured population. And the data goes back all the way to 2013. So we have a lot of trend information. So this is a really robust database that we get to use. What is not in the Colorado APCD? Federal programs such as the VA, TRICARE, Indian Health Services, major ERISA-based self-insured employers, uninsured and self-pay claims, and some supplemental info is not. And what do we do with all this great information? So how do we inform? Well, we turn the information in both public and non-public data. So public data is what we're going to be talking about today, what's in the health equity analysis. We also have a slew of other public reports you can find on our website, civhc.org. And then we also, non-public data is also licensed to those change agents working to advance the triple aim, and that meets specific project needs. So you can find more information about that on our website as well. And from there, I'm going to toss it over to Carrie Frank.
Thanks so much, Claire. Thanks for the introduction. As Claire mentioned, we're very excited. This is our first foray into a public analysis that really digs deeper into health equity and this what we call social determinants of health. So why is it important? There's a lot of evidence that shows that non-medical factors outside of somebody's control, like where you're born, where you live, your situation, your age, your race, those are all factors outside of your control, and they really drive about 80% of a person's health is related to those social factors. So because of that, it's really important to dig deeper. We have information, as Claire said, from the Colorado All-Payer Claims database that shows, cost, utilization, health outcomes, but we've never been able to see the impact of social factors when you're looking at the information that we have. So really, that was the question we were trying to answer: is how are social factors outside of folks' control, how are they related to healthcare use and ultimately folks' health? And so what we did is we partnered with our good friends at HSRI. They actually came up with a brilliant idea. They're like, let's do something. Let's figure out how to do it. So we worked a while ago to be able to set the foundation for creating this report. And really what it does is shows the relationship between the social factors and access, use, and quality of healthcare services in Colorado. And the intent is to support communities and policymakers, public health professionals, and other decision makers to really hone in on, where can we focus our efforts? We know that social factors play a role, but which ones are most important? What kinds of things are they driving? So again, the infrastructure was also a partnership between HSRI and CIVHC. Back in 2020, what we did is we geocoded the APCD, and that is just a fancy term for pinpointing where everybody lives. So we took addresses from the APCD claims data and made a latitude and longitude reference for each and every member who's in the APCD. So then that way we can assign folks to census tract level information, and that is how we were able to pull this information in. So the health equity analysis really looks at what are those impacts of social determinants and social factors on three areas: cost, utilization of healthcare service, and access. So the social factor information isn't in the APCD. That we don't get income information, we don't know education levels, none of those things. So it's really important, again, to have that census level identification within the database so that we could pull that data from other sources. So there are two sources that we use. One is the Census Tract American Community Survey, and that data is all publicly available. Many of you probably are using it. So the three measures that we're using from the census data is income. So we looked at percent of people living in areas below the poverty line. Education, which is percent of people without a high school diploma, and then employment, which is the percent of people who are unemployed in that area. The other two measures are composite measures, and those we took from the Centers for Disease Control Social Vulnerability Index, and those two were housing and transportation. So it's folks who are living in either crowded housing situations. It's not just crowded housing. The whole measure is available. If anybody's interested, we can put the link in the chat box. But it's crowded housing and or without a vehicle. And that's a percentile ranking. And then we also looked at race, ethnicity, and language preference. We do collect some race and ethnicity information, and we're collecting language preference in the APCD now, but it is not something that payers collect in a robust way, especially the commercial payers. So it's not as reliable as the CDC Social Vulnerability Index. So that's looking at people of color and people with limited English. So then we married those social factors with what's in the Colorado All-Payer Claims database, and these measures were taken from our community dashboard. We have a lot more measures in the community dashboard, but we wanted to look at access to care, quality of care, cost of care, and utilization of services. So the two access to care measures that we pulled from the community dashboard were our kids and adolescents accessing care and utilizing it for preventive ways, the way that they should. Similarly, with adults, we looked at lack of access to care for adults. For the quality measure, we looked at folks who were going to the ED for mental health services and whether or not they were getting a follow-up visit with their primary care physician or with other provider within 30 days. We also looked at cost of care per person per year. So what does spending look like for people in certain areas? And then 2 utilization measures. One was all ED visits and then potentially preventable ED visits. And again, all of those were based on our community dashboard, which is also all brand new and up to date on our website too. So I'm going to jump out just so you understand. I think for me, especially, I am a visual person, and so seeing this tool in action is really more meaningful than me yapping at you and telling you what's in it. So if you go to our website, we are civic.org, CIVHC.org, and if you go to the Get Data tab and the public data, and you click on focus areas, that's where you're going to find this health equity analysis. So I'm on the page now, and I will scroll up. Sorry, my screen is in the way. So if you land on this page at the beginning, there's some intro, just why this report is important. And then you can see some examples and just some descriptions of how to use the report. Understanding the results is kind of challenging if you don't have a stats degree, and Jamie's going to go over a little bit more about that. But really the important thing to be looking at is this R value, which is the correlation value. And this scale here shows what scale between 0 and 19 is a weak or no relationship between the 2 measures that you select, up to a very strong relationship is 1.0. And it gives you an example of that too. So if you ever are, if you're not remembering how to use this tool, that all of the instructions are there. So what we have here is on the upper left-hand side, you have the social factor element. So you have those 5 areas: income, education, employment, housing, and transportation. I will leave it on income. And then you have healthcare measures that you can select. So the default is going to be all ED visits. I'm going to switch it to potentially preventable ED visits. One thing that you have to note is that Tableau is, we're fighting with Tableau, and it always is going to give you this strange warning sign. Just click on it, it goes away, and the report works just fine. So this is looking at the comparison between income level, so the percent of people below poverty, and potentially preventable ED use. So you can see, if you look at the R value, which as I mentioned before, that is the correlation, and the scale is here if you don't want to scroll back up. So anything really above a 0.4 indicates a strong to a very strong relationship. And so what we're seeing at a 0.75 is that across Colorado, we have all of Colorado selected. ED visits, potentially preventable, are very strongly correlated and strongly related to the percent of people below poverty level. So if over down here in the lower left-hand side is where you have lower levels of poverty and you have lower utilization use, as opposed to up here in this top area is where you have more of the higher poverty levels, higher percent of poverty levels, and higher use of the potentially preventable ED visits. So this one we're looking at right here is Pueblo County. Each one of these represents an actual census tract, and these are the quartiles. So this is the upper quartile, and then you have the lower quartile, and we just color coded them so that you can kind of separate them in your visualization as you're looking around here. So let's say that you just want to see what this looks like across Colorado. This is all of the census tracts. Obviously, if you zoom in, you'll start to get into the closer, into the areas that you may be wanting to see down in the map. You can always pop back out in these areas and refresh it if it's being silly, which is going to be silly for me. And the other thing to note when you're down here looking, you also have the breakdown of the race ethnicity on the side. So this is all of Colorado and the breakdown of Hispanic, non-Hispanic, white, and then non-Hispanic of other races, the green. If you look down here, whatever neighborhood you select, you can also get the breakdown right there of the race and ethnicity. So as I mentioned before, let's look at Pueblo. It has that high rate of poverty level and also high rate of utilization of ED. So if you wanted to isolate just Pueblo and see what's going on in that Pueblo area, you will see that it varies, right? So there are many census tracts within Pueblo. And so if you wanted to look at what's going on, you have some neighborhoods. If you look at this scale down here, green means lower percent of social risk factors and more appropriate use of healthcare measures, as opposed to the upper red is kind of the flip of that. So lots of things that you can do at the community level. Jamie's going to give you another use case. So I'm not going to dig into other types of use cases, but if you remember that our value that we had for across the entire state for potentially preventable ED visits and income, it was about 0.5. So for Pueblo County, there's even a stronger relationship between those at 0.75. And I know that's very detailed information, and so we took it up a level and we created this infographic here on the right-hand side. You can download it, but it looks like this, and we have to give our analysts and our designer huge kudos for this. I'm going to pop back out and show you these sections of the infographic one at a time, just so you can get some more insights about what's happening statewide and which factors are really related to each other. So we found a few interesting notes. So as we were just looking at the social factors, we saw that all of them, no matter which one you chose, we were looking at income, but every single one of the social factors that we have, so income, education, race, ethnicity, all of them were related to not only just ED visits, but also the preventable ED visits. We also found that all of the social factors across Colorado were strongly related to adults not receiving preventive care, which we of course want everybody to be receiving preventive care. That prevents a lot of downstream effects and keeps you healthy. But we interestingly did not see any of the social factors impacting kids and adolescents receiving their preventive health care. And that was not something that we expected to find. None of the social factors, even income, education of the household, none of those things impacted kids and adolescents receiving preventive care, which we can, I think, attribute a lot of that to a very solid Medicaid system and support system and safety net here in Colorado. There are probably other reasons for that as well. We don't know all the reasons, but there's obviously some speculation there. None of the social factors impacted cost of healthcare services either per person per year. So regardless of any of those factors, the cost of care was not really associated with that. And then we did see just a very moderate to weak relationship between the social factors and people receiving a follow-up visit for after going to the emergency department for a mental health need. So the two areas that were most strongly related, again, were ED visits and access to care for adults. So this is what it looks like if you were to graph it out. Across the top are the social factors: income, education, employment, housing, transportation, and ethnicity. And here are all the healthcare measures. So this is the relationship table legend up at the top. So the orange indicates a strong relationship, the gray is a moderate relationship, and the green is a weak. So again, as I was mentioning, the children and adolescent access to care, you can see, are all green. That means there's no relationship or very weak relationship. The adult access to care, however, you see that both income and education are very strongly related to adults not receiving care. Employment wasn't as strong, but there was still a moderate relationship there. Definitely housing and transportation and race, ethnicity, and language preference, those were very strongly related to adults not receiving care. That follow-up after ED visit, not as much relationship, again, between the social factors. Income was a little bit more strongly related. Housing and transportation was a little bit more strongly related, but education, employment, and race and ethnicity did not play a factor. Again, cost of care, not at all related, or very weak relationship between all of the factors. But here's our potentially preventable ED visits. And again, all of the factors were very strongly associated with people going to the emergency department for a potentially preventable reason, which of course we do not want folks to show up there. And it's not the best source of care. It's more costly. There are lots of issues there. We also dug deeper into rural versus urban, and Jamie's going to go into even more analysis of this, but just at a high level across all of Colorado, in urban neighborhoods, all of those social factors were strongly related to the potentially preventable ED visits. However, when we looked at all of the rural neighborhoods, only income and education were strongly correlated with the ED visit. So a little bit different view when you look at rural versus urban. Also, a little bit of difference between rural neighborhoods when it came to the adults not receiving preventive care. Income was the only thing that was strongly related, as opposed to the urban neighborhoods where all of the social factors were strongly related to adults not receiving preventive care. So there's a lot you can do with this. We also took some time to dig into just Denver, because Denver County is very different depending on where you go. So we looked at two different scenarios. This one in particular was evaluating lower percentages of income or lower income levels with that potentially preventable ED visits. And we evaluated two side-by-side neighborhoods, the Sunnyside and Highlands. And then we also looked at two that were within, a 15-minute car ride, 6 miles apart. So those were Cherry Creek and Elyria, Swansea. And what we found there was similar things. So very different results depending on even neighborhoods that were bordering each other. So the nearby neighborhoods, the Elyria, Swansea, you had 20% of the people were living below the poverty line in that neighborhood. We saw 29% of the residents had a potentially preventable ED visit. We just drive not too far to the Cherry Creek area, a much smaller percentage of the population living below the poverty line, and a much smaller rate of residents having potentially preventable ED visits. Similarly, just bordering Highlands neighborhood and the Sunnyside neighborhood, and in the Highlands, it's changing. Only 6% of folks are living below the poverty line at this point, and 1% had a potentially preventable ED visit, but you just crossed the border there. And a very different story in the Sunnyside neighborhood, where 27% were living below the poverty line, which are driving, and closely related to 18% of the people having a preventable ED visit. We did the same thing for Denver neighborhoods related to the diversity of the population, so that race and ethnicity measure and the language preference, and looking at the access to care. So here we looked at Globeville and Central Park, which are close, they're a 7-mile car ride, and Sloan's Lake and West Colfax, which are bordering neighborhoods. And so we saw where we had more diversity in the Globeville area and more diversity in the West Colfax area. We had much higher rates of adults not receiving preventive care, 57% and 47%, as opposed to in least diverse neighborhoods. We saw that 27% of adults weren't receiving preventive care and 23%. So there's a lot you can do with this. That is the end of my section, and I want to turn it over to Jamie to get a little bit more into the statistics weeds, because that is her area of expertise, definitely not mine. And I can't thank our partners at HSRI enough. Haley's on the phone too, and Awana, who is out of the country. We're masterminds behind this, and we're really grateful for their partnership. So I'll let you take it away, Jamie.
Sure. I'll also shout out our Tableau developer, Danny, as well, for her help on this. Yeah, so my name is Jamie. I work at Human Services Research Institute, which is a mission-driven nonprofit organization. And we've partnered with Civic for the past 7 years now, transforming the Colorado APCD into a high-quality data source. I'm on the population health team, which builds data systems to collect, analyze, and report healthcare data to improve the quality of health information available for research, policy, and practice. Next slide, please. And I will give you all an overview of our urban and rural analysis. So for this analysis, we used Pearson correlation coefficients, which I'll go over how to use them in a little more detail later. Um, this is the general differences between urban and rural Pearson correlation coefficients between SDOH measures and healthcare measures. Now, in general, probably the biggest finding that you want to take away from this analysis is that in rural census tracts, the relationships between social determinants of health and healthcare measures were less strong than they were in urban census tracts and in overall census tracts. So you can see that relationship especially well in the access to care in adults measure and the potentially preventable ED visits measure, which is the second row and the last row. You can see in rural census tracts, these relationships are more moderate, but in urban census tracts, they're strong. Next slide, please. So we're going to get into specifics in access to care in children and adolescents. More crowded housing and transportation resulted in lower access to care in urban areas, but we didn't see that effect as much in rural areas. But in rural areas, there was a moderate relationship between higher race, ethnicity, language, diversity, and actually better access to care in children and adolescents, which was pretty interesting. Next slide, please. So the next measure I'm going to focus on is follow-up after an emergency department visit for mental health. In urban areas, more crowded housing and less access to transportation resulted in lower follow-up rates after ED visits for mental health. Whereas in rural areas, we found that relationship for employment, but not for housing and transportation. So that was a key difference there. And then our next healthcare measure we're going to look at is cost of care per person per year. In urban areas, we saw moderate relationships between education and race, ethnicity, and language and cost of care per person per year. But in rural areas, we saw a relationship between income and cost of care per person per year. So next slide, please. Those were our findings of that analysis, but now let's go over a little bit about Pearson correlation coefficients in general, and then we'll get into how to use them with this dashboard. So if you have ever taken a statistics class, you've probably heard the phrase, correlation is not equal to causation. That just means that though two things might be strongly related, they might not have a cause and effect relationship. So this example that I'm going to walk us through is ice cream shop sales by month and shark attacks by month. If you look in the graph to the right on the bottom there, you can see that ice cream sales peak in the summer, but so do shark attacks. Even though those two variables are strongly related, it doesn't necessarily mean that ice cream shop sales cause shark attacks or that shark attacks cause ice cream shop sales. That doesn't really sound like a likely explanation. So next slide, please. So if this relationship is not cause and effect, what could be the possible explanation. More likely explanation is that temperature affects ice cream sales and shark attacks in the same way. Because when it gets hot, people need to cool down. That makes temperature a confounder. That's a fancy statistical term that just means that temperature affects ice cream sales and shark attacks in the same way. Although correlation can indicate that two things have a cause and effect relationship, we can't assume that. We have to consider the context of our results for the most likely explanation for them. So next slide, please. To summarize, when we're using correlation coefficients, it's important to consider the context of your data when interpreting those statistics. And if we cannot assume that correlation is equal to causation, how do we use correlation coefficients? Well, correlation coefficients are most useful as hypothesis generators. And they're most useful to come up with explanations for why the world is the way it is. So once we've generated a likely hypothesis, we can develop experiments to prove or disprove it, develop further statistical models to explore the relationship, or use the health equity dashboard to explore it, which I will give an example of later. And then once we've found a likely one, we can develop public health or policy interventions that can address the root cause of the problem. Next slide, please. So in this example, we're going to come up with a potential hypothesis and then take a look at whether we think it's likely or not. Next animation. So let's say you are a public health worker in a rural county in Colorado. You're interested in access to care for children. Next animation, please. So in looking at the health equity dashboard, you can see that in urban census tracts, higher race, ethnicity, language diversity is weakly related to lower access to care in children, but in rural census tracts, higher diversity is moderately related to higher access to care in children and adolescents. Next, please. You hypothesize that poverty is related to this difference. And then you can see your little hypothesis on the right there. You think, could rural census tracts that are diverse have less poverty, but urban census tracts that are diverse have more poverty? And then one more animation. Could that somehow modify the relationship between diversity and access to care in children? So next slide, please. So to take a look at whether this hypothesis is likely or not, we're going to use the dashboard. So you hypothesize poverty was related. After further investigation, you think, oh, this isn't very likely. And then could you do the next two? Thank you. So you highlight, you can select by clicking and dragging on the dashboard census tracts. So you highlight for the urban counties, census tracts with ratings greater than 0.7, and then you switch using the select SDOH filter over to income, and you can see that the distribution of incomes there is pretty similar to not as diverse census tracts. And then you do the same thing on the bottom for rural census tracts, and you see that that distribution is pretty much the same, and there's no real difference between highly diverse urban census tracts and highly diverse rural census tracts. So just by looking at the dashboard, you're kind of able to figure out that this hypothesis it's not very likely. And then I'll turn it back over to Carrie and Claire.
Thanks so much, Jamie. We got so many questions in the chat, and I was able to answer most of them, but if I wasn't able to get to your question, or if I missed it, please throw it in the chat now while we do some questions and feedback and do some last minute housekeeping.
I'll take a look.
Yeah, thank you for everybody who made suggestions and asked for more information. We do have further breakouts as we're sharing in the chat in our community dashboard, and I can pop out to the community dashboard too if that's helpful. So the age breakdowns and kind of more of the detailed demographic slices is available in the community dashboard. And if you don't see it in the dashboard itself, we have underlying data that you can grab as well. And we have, I think, 44 different Excel files that feeds the community dashboard data. So very robust if you're interested in accessing any of that. I can show you where to go here. If you're on our website, it's again under that get data, public data, focus areas. The community dashboard is right above our health equity analysis, which we just shared. And I think it was a good question. I believe it was David Downs. Thank you for posing the cost of care question. We do have cost information broken down by different types of inpatient, outpatient, and pharmacy. So you can actually look at a region. We can go back to our Pueblo County. This is a summary of all of the dashboard measures here. But if you chose our Pueblo County friends here, and this is also where we have breakdowns, and we also had questions about, can you look at the data by payer type? We do have all of the community dashboard measures broken out by payer type. We don't have the health equity analysis available that way right now, but that is something we have for plans for the future. But if you look at all payers, we'll select all payers. We have to go to 2020 here. You can look at, this is health plan and patient total cost. So you can see inpatient, outpatient, professional, and pharmacy. So you could kind of start to dig into, well, maybe the folks aren't using as much inpatient services. It looks like actually inpatient is higher for Pueblo than the statewide average. This is what this little orange arrow up indicates. Their outpatient is lower. Professional is higher and pharmacy is higher. So that's not going to give us a ton of information there. But if you think about the fact that folks aren't going to get sick care, even if they're going to the ED to visit for their actual source of care, it's probably still going to be lower than if they're going for regular checkups and all of the things, the diagnostic tests and things that they may need. So that might be one way to explain that that there's no correlation to the cost of care per person per year. More quality measures and more utilization measures are here as well. So you can also look at things like hospital admissions, potentially preventable. We have the breakout of the well child visit. So you can look at the different age groups within here. You can also see the healthy users per 1,000. So that is people who are who have insurance, who are actually using their insurance, and then non-users, so people who have insurance that aren't going. So I just wanted to share that. This is hot off the presses too, by the way. We haven't even publicized that the community dashboard is live, so you guys are getting a sneak peek. Claire's probably like, why are you showing this, Carrie?
No, it's a great tool. I'm glad you were able to demo it because there's so much data in it as well. So it's really robust.
Yeah. But we'd love if anybody has more feedback for us as you're using it. We'd love to hear more about how you're using it. I know some folks down in the Durango area have already started plotting out in Excel tabs, like the different measures and how each of their census tracts are impacted. And they're going to be using it in the discussions with their planning, with their public health department to see where they want to focus their efforts and to see, how they can use this in kind of a dashboard view to track their progress over time too. So we'd love to hear feedback on how you're using it, how it could be better, because that's one of our goals for all of our public reports is to make sure we're meeting the needs of all of you out there in the community who are doing excellent work. So do we have any other questions come in?
Does not look like it. No, I think
awesome.
That's it.
Well, wonderful. We're going to give everybody 20 minutes back in their world, and we appreciate all of your support and for you joining us today. Thanks again to Jamie and HSRI team for all of your work, and we look forward to the next Data to Drive Decisions with you guys in May. The topic is around our scholarship process and more details to come. So thanks for joining and have a great rest of your day, everybody. Bye-bye.